Hi friends. Yesterday we had discussed about the anatomy, physiology, a little bit of embryology and some of the functions of the thyroid gland. So what are all the two manifestations of thyroid? Okay. What are all the two manifestations of thyroid? So thyroid can, remember, thyroid is essential for almost all functions of the body. Almost all functions of the body. Okay, each and every tissue requires thyroid gland for its function. The manifestations of thyroid can be either hypothyroidism, in which it is not acting. One is hypothyroidism. Second is hyperthyroidism. Second is hyperthyroidism. The most common cause for hypothyroidism can be either congenital or it can be acquired, either congenital or acquired, right? So congenital or acquired. With respect to congenital, the most common cause, as we discussed already, is thyroid dysgenesis. That means absent thyroid gland, or it can be ectopic thyroid, or it can be dysharmonogenesis. What is that? It can be disharmonogenesis. What do you mean by disharmonogenesis? You know, many thyroid peroxidase, iodinase, deiodinase, iodine trapping, so many things have been happening during the formation of thyroglobulin. Whenever there is an issue with any of these enzymes, your thyroid gland will be there structurally, but it will not produce function. It will not produce your T3 and T4 due to the absence of those enzymes involved in the thyroglobulin production or T3 T4 production. That is called disharmonogenesis. So one is thyroid dysgenesis, absent thyroid, ectopic thyroid, disharmonogenesis, and the last one is iodine deficiency. Last one is iodine deficiency. That is endemic iodine deficiency. Endemic iodine deficiency. Or it can also be due to maternal antithyroid drugs. It can be also due to maternal antithyroid drugs if the mothers are taking antithyroid drugs. So these are all the common causes for congenital hypothyroidism. Remember, in the first two, thyroid dysgenesis and ectopic thyroid, whenever you do ultrasound, thyroid will be absent. Thyroid will be absent. Whereas in other cases such as disharmonogenesis, iodine deficiency and maternal antithyroid drugs, in these three cases, you will have something called neonatal goiter. Something called as what? Neonatal goiter. Neonatal goiter. So in the first, so there are commonly 5 conditions you have. There are 5 conditions. In the first 2 conditions, you will have absent thyroid. Or even your ultrasound cannot pick up your ectopic thyroid gland. Whereas other 3 conditions are associated with neonatal goiter. Right. Now, ectopic goiter. Okay? Right. Now you have what is the acquired cause for hypothyroidism? What is the acquired cause of hypothyroidism? The most common thing associated with acquired hypothyroidism is very simple. It is your Hashimoto's thyroiditis. It is Hashimoto's thyroiditis. Hashimoto's, acquired hypothyroidism. And then when it comes to what is that hyperthyroidism, it can be due to two things commonly. One, with goiter. Another thing is without goiter. Without goiter. With goiter means usually it is Graves' disease. What is that? Again, autoimmune thyroiditis associated with increased function. Whereas Hashimoto's means usually decreased function. When hyperthyroidism associated without the goiter, it can be due to autoimmune thyroiditis. It can be due to autoimmune thyroiditis. It is nothing but thyrotoxic phase of Hashimoto's thyroiditis. Hashimoto's thyroiditis is nothing but autoimmune thyroiditis. Okay, so very simple. These are all the things that you need to know basically with respect to hypo and hyperthyroidism. Now let us come to the manifestations of hypo and hyperthyroidism. So in blue let me write hypothyroidism, and red I am going to write hyperthyroidism. So let me finish hypo first. Okay, remember hypothyroid patients have poor calorigenesis. Calorigenesis means what? Calorigenesis means the body, because of sodium potassium ATPase, can produce or can induce calorie or heat production. In hypothyroid, they cannot mount heat generation in the body, as a result of which invariably they will have cold intolerance. What do you mean by cold intolerance? Cold intolerance means they cannot tolerate cold environment, because during cold your body is supposed to produce heat, which cannot be done in hypothyroid patient. So they used to say they cannot tolerate between November, December, January month where cold environment prevails in our country. One. Second, sweating. Hypothyroidism is associated with decreased sweating. Weight gain will be more. Why more? Because of the accumulation of glycosaminoglycans. Glycosaminoglycans are the connective tissue particles that is present in the collagen. These glycosaminoglycans are broken down by means of thyroid hormones. When thyroid hormones are not present, there will be accumulation of glycosaminoglycans leading to weight gain. And you can also say, people used to say, yeah, previously, hypothyroidism can be diagnosed through phone. Why? Because when these glycosaminoglycans are deposited in the vocal cord, there will be a voice change. There will be a hoarse voice. So, a gradual onset hoarse voice in an adult is usually hypothyroidism. So this can also due to voice change can be there. Edema. Edema, again it is due to glycosaminoglycans, that is generalized edema. Generalized edema. And also it is due to what? There is free water retention will be there. I repeat, water retention will be there, as a result of which edema will be there. Generalized edema will be there. Skin is usually cold to touch. What about eyes? Eyes are puffy. What about bowel? They have decreased bowel leading to constipation. Muscle, they have myopathy, that is called hypothyroid myopathy, leading to proximal muscle weakness. That means they cannot do this kind of movements. Okay, so climbing, proximal muscle movement, involvement of proximal muscles of lower limb, elevating or abducting your shoulder, means proximal muscle movement of upper limb. They cannot comb, upper limb proximal myopathy. They cannot climb, lower limb proximal myopathy. Activity, they will be sluggish. They will be sluggish. Reflexes are all reduced. Deep tendon reflexes are all reduced. And remember, one important cause for bradycardia is hypothyroidism. Then you are free T3, free T4. Usually what we had discussed yesterday, we measure free T4 rather than free T3 because free T4 is the one which is stable, whereas free free T4 will be converted into free T3 based on the body's requirements. So I can say this is the storage form and this is the active form. So we measure free T4. Free T4 will be invariably low, whereas TSH will be invariably high, presumed that there is a problem in thyroid. So that is primary hypothyroidism. Hypothyroidism. This is with respect to hypothyroidism. Now let's come to hyperthyroidism. Since already there is excess calorigenesis in heat environment, particularly during May, June, July, they cannot tolerate. So heat intolerance is the manifestation of hyperthyroidism because already there is increased calorigenesis, increased heat production in the body. Cold intolerance? No. And then what about sweating? Always their palms will be wet. Increased sweating. Palms will be wet because of increased sympathetic activity. And then weight loss will be there because of excess calorigenesis. Weight loss will be there. Edema. Most common cause for hyperthyroidism is Graves' disease, in which there is autoimmune mediated deposition of connective tissue or fluids in tibia, that is called pretibial myxedema. Pretibial myxedema. Pretibial edema. I can't say myxedema. I need to say pretibial edema. That is, edema will be present only over the tibia. Generalized edema is a feature of hypothyroidism, whereas pretibial edema is a feature of hyperthyroidism, particularly Graves' disease, not due to Hashimoto's thyroid toxic phases of Hashimoto's thyroiditis. Okay, then skin will be warm to touch. Skin will be warm to touch. Eyes, because of sympathetic overactivity, you have proptosis. Why you have proptosis? Because of autoimmune deposition of connective tissues behind the orbit. So you have proptosis. Also, because of sympathetic activity, you have lid lag. So because of the pull of the Muller's muscle by the sympathetic activity. So when you ask him to close his eyes, he will take some time to close his eyes, not suddenly. That is called lid lag. Constipation here, increased bowel movement leading to diarrhea. And then myopathy. In hyperthyroidism also you will get myopathy. So myopathy is the manifestation of both hypo and hyperthyroidism. Sluggish, they are alert. Thyroid means alertness. They are overactive. What about deep tendon reflexes? Deep tendon reflexes are exaggerated. Heart rate, tachycardia. Any adult with a sudden onset cardiac decompensation, always rule out hyperthyroidism. The most important clue for hyperthyroidism is tachycardia. And then what about free T4? Free T4 will be very high, whereas TSH will be undetectable. As I told you already, the most common cause is Graves' disease. Graves' disease. So these are all the salient manifestation of hypo and hyperthyroidism. Whether it is a newborn or a child or an adolescent or an adult, this is the same for both, for any age group. Now, so let me finish congenital hypothyroidism, a very important topic for your entrance examination. Right, congenital hypothyroidism, what is the most common cause? I told you, my dear friends, it is thyroid dysgenesis. Thyroid dysgenesis, or it can be due to ectopic thyroid. Thyroid dysgenesis can be picked up by ultrasound thyroid, whereas ectopic thyroid can be picked up by technetium 99 scan, otherwise known as scintigraphy. What are all the causes for goitrous hypothyroidism? As we discussed already, three causes. One is dysharmonogenesis. One is dysharmonogenesis. The second one is maternal antithyroid drug. The third one is, what is the third one? Iodine deficiency status of the place. But majority, it usually occurs in hill places. What is the investigation of choice? To find out congenital hypothyroidism. So free T4, usually T4 is enough, and TSH. When TSH is high with low T4, it is congenital primary hypothyroidism due to thyroid dysgenesis. Whereas when free T4 is low, TSH is also low, means it is either hypothalamic or pituitary disorder. So you need to take an MRI brain to find out the structural defect involving your thyroid. Sir, how to identify this hypothyroidism? 6 P's are there. What are all the 6 P's? 1. Poor mentation or reduced alertness of the newborn. The child will be sluggish. 1. Second one is pale faces, puffy faces because of glycosaminoglycan deposition. And then you have protruded tongue. Any newborn with protruded tongue should be investigated for congenital hypothyroidism. Protruded umbilicus and then protruded abdomen. All these things are 6 P manifestations of congenital hypothyroidism. Okay, congenital hypothyroidism. What is the dose of thyroxine? Minimum of 10 microgram per kilogram per day. Should be started. When to start? As early as possible. Because when you delay it, it will lead to some neurological sequelae. So ideally, it should be started within 2 weeks after birth. It should be started within 2 weeks after birth. Sometimes you can stop and observe. What is this? In congenital hypothyroidism, you can stop and observe. Yes, rarely. By about 3 years, stop and wait for TSH elevation. If after stopping, if TSH is elevated, so permanently you need to give the child thyroxine tablets. But if at 3 years, when you stop and TSH normal despite stopping, it means the child starts produce on its own. Usually it occurs in some forms of dysharmonogenesis. Some form of dysharmonogenesis. Okay. Right. This is all about congenital hypothyroidism. Short question. All babies, irrespective of features of hypothyroidism, should be investigated with TSH, if possible T4. That is called as universal screening. Called as universal screening. Okay, this is about congenital hypothyroidism. Next comes acquired hypothyroidism. The most common cause for acquired hypothyroidism is, as it is mentioned, it is Hashimoto's thyroiditis. What is that? This is an autoimmune disease. Immune disease. So what will happen on palpation? Because of the lymphocytic infiltration, the thyroid will be firm and nodular. Whenever any girl presents with firm and nodular goiter in and around peripubertal age group, it should be considered as a case of Hashimoto's thyroiditis. Always painless. Always painless. Painful thyroiditis is less likely to be due to autoimmune or Hashimoto's thyroiditis. How do you know that it is antibody mediated? It is Hashimoto's thyroiditis antibody mediated. What are all the two most common antibodies? One is antithyroid peroxidase, and another is antithyroglobulin. Antibodies to thyroid peroxidase and antithyroglobulin. So most common is antithyroid peroxidase followed by antithyroglobulin. Remember, since it is an autoimmune disease, it can be associated with other autoimmune diseases such as diabetes mellitus or rheumatoid arthritis, particularly type 1 diabetes mellitus. When any child presenting with one autoimmune disease, invariably it is prone for other autoimmune diseases. Syndromes, remember, all Down syndrome, all Turner syndrome should be periodically screened for hypothyroidism, should be periodically screened for Hashimoto's thyroiditis. They are very prone for Hashimoto's thyroiditis. Manifestations of this Hashimoto's thyroiditis, since it is acquired. So as usual, you can have bradycardia. As usual, you can have reduced sluggish. The child will be sluggish, increased weight gain, voice change. These are all common for both dry skin. But what happens in Hashimoto's thyroiditis? Short stature is also a manifestation. Height will be very much compromised. Second point is delayed puberty. The puberty, instead of occurring between 10 to 14 years, it can be postponed. Delayed puberty. These are all the manifestations of Hashimoto's thyroiditis. Remember, in Hashimoto's thyroiditis, there are two phases. It can have thyrotoxic phase, but usually treatment is not required, but ultimately they will go for hypothyroidism. At that time, you may need thyroxine supplements. So any adolescent girl with painless For nodular goiter should be investigated for Hashimoto's thyroiditis with antibodies to thyroglobulin and antibodies to thyroid peroxidase. Okay, any child with a short stature should be investigated for female child Turner syndrome. Any child with a short stature female child should be investigated for hypothyroidism, particularly Hashimoto's induced hypothyroidism. So congenital we had seen, acquired is autoimmune thyroiditis, AIT, that is Hashimoto's thyroiditis. And finally, what is that? What is that? Already it was discussed to you. Whenever you have a hyperthyroidism without goiter, it is usually thyrotoxic phase of what is that? Thyrotoxic phase of just now Hashimoto's. Phase of Hashimoto's. When you do a scintigraphy, that is technetium scan, there will be poor uptake because the gland is getting destroyed. Poor uptake. Okay, here there is no role for anti-thyroid drugs. Where hyperthyroidism without goiter, whereas when you have hyperthyroidism with goiter, it is usually, and remember in these cases, that is thyrotoxic phase of Hashimoto's thyroiditis, there will be absence of proptosis. It will not be present. There will be no pretibial edema. There will be no pretibial edema because they are all due to TSH stimulating antibodies of hyperthyroidism with goiter, whereas hyperthyroidism with goiter is the most common cause is Graves' disease. What is that? Most common cause is Graves' disease, in which there are stimulating antibodies to thyroid stimulating hormone, so they work more. It is characterized by pretibial edema. It is characterized by proptosis. It is characterized by lid lag. Graves' disease. Okay, so anti-thyroid drugs are required in Graves. You have methimazole, propylthiouracil. Methimazole is used in children, whereas propylthiouracil is not used in children because they are prone to produce hepatotoxicity. What other drugs that can be used in case of Graves' disease? T4 will be converted into T3. You all know. This conversion can be inhibited by steroids. This conversion can be inhibited by steroids, as well as the effect of T3 over the tissues can be reduced by giving beta blocker such as propranolol. And finally, rarely iodine 131 are used to destroy thyroid gland, but it can lead to permanent hypothyroidism. Okay, so with this, we are completing our 30-minute short discussion on congenital hypothyroidism, acquired hypothyroidism, hyperthyroidism, and some of the difference between hypo and hyperthyroidism. Thanks for your patient listening. We will meet next Wednesday and Thursday with some other same topic.